Hello everyone and welcome to Stud Diet. Today we are going to learn about hard contact lenses, right? So hard contact lenses by their name tells you that something that is worn onto the surface of the eye but it is hard in nature, right? So the hard contact lenses are the type of optical device that is directly worn onto the surface of the cornea but are very hard and are used for special purposes, right? So let's move on and see that what are hard contact lenses and what is the importance of the hard contact lenses. So hard contact lenses are also known as RGP lenses, which mean that they are the rigid gas permeable lenses that allow the gas to pass through them, right? These are the contact lenses that allow, or they have the permission, they allow the gas to pass through them. So they are the gas permeable uh, contact lenses, and they are more durable, they are long lasting. If we are taking proper care of these contact lenses, they can last up to 1 year, and they are allowing the oxygen to pass through them. So they are made of certain material that can allow the oxygen to pass through them and can reach to the cornea. So what we know about the contact lens is that when we are applying anything onto the surface of the cornea, we are wearing a contact lens, there are a lot of risk of the neovascularization and dryness of the cornea, because the cornea gets its nourishment from the air environment, tear film, and from the inner side it gets its nourishment from the aqueous humor. So if the any of these two sources of nutrition to the cornea is blocked, what will happen, the cornea will be dried and eventually it will give there will be some neovascularization, and due to neovascularization there will be blindness. So contact lenses are made in such a way that contact lenses should give enough oxygen to pass through them and to reach the cornea in order to provide nourishment, right? So that is why the hard contact lenses are should be made of those materials that allow the oxygen to pass through them and to reach to the cornea. They are very gas permeable now, but still they are hard, they are rigid. That is why they do not change its shape, so they are less flexible. And when we apply it onto the surface of the cornea, they do not change their shape, they maintain or retain their shape as they were on your hand. They will be same while you apply onto the surface of the cornea. And unlike the soft contact lenses that used to get stick to the surface of the cornea, the soft contact lens, what is the property of the soft contact lens, that they are water loving and they get stick and strictly and tightly adhere to the corneal surface. But hard contact lens does not get stick to the surface of the cornea, but there is a space between the cornea and contact lens, which is the layer of the tears, right? So they do not change their shape, and they are very ideal for the certain conditions like keratoconus, keratoglobus, irregular astigmatism, or any other corneal irregularity which we known as the corneal ectasias, right? So although the adaptation period of the hard contact lens is very long, it is about 13 days, 2 weeks to 13 days, and the patient feels very uncomfortable during these adaptation period. But if once the adaptation is completed, it is very easy for the person to handle the contact lens, right? So the history of the contact lens is that the first emerged contact lens was hard contact lens that was made of polymethyl methacrylate material, which is also known as PMMA. But the drawback of this material was that it does not allow the oxygen to pass through it. So what happened that due to the less oxygen that was reaching to the cornea dried, and there was neovascularization in patient's eye, and thus they have a lot of discomfort as well. So that is why the originally made hard contact lenses get into further modifications, and there was another type of the contact lens made that was soft contact lenses, and later there were more modifications that made the hard RGP lenses. The first contact lens were rigid non-gas permeable hard contact lenses, but later, due to the neovascularization, dryness, and discomfort, because the material does not allow enough oxygen to pass through them, there was a need to make some type of contact lens that can allow oxygen to pass through them, right? So that is why RGP lenses were made, which were made up of certain materials like silicone and CAB material, which is also known as cellulose acetate butyrate. So these are the two materials by which the RGP lenses are made up of, and they allow the oxygen to pass through them. So this is the what I mean by the passing of the oxygen, that every contact lens should have an ability to pass or to allow the cornea to get its oxygen or nourishment from the environment. So how that is allowed? It is allowed by passing the oxygen from contact lens and to allow this oxygen to reach to the corneal surface, right? So after the non-permeability of hard contact lenses, RGB contact lenses were made, and they what they do, they provide more comfort, and they have compared as compared to PMMA, they are much better contact lenses, right? So they allow more oxygen to pass through them, and that is why all that dryness issues, neovascularization issues have been removed. And if we have if a patient takes a proper care of the contact lens, there are so much reduced chances of the infection, and it gives more comfort to the patient as compared to soft contact lenses as well. So what is the properties? It provide a clear, crisp vision. You get much more sharper vision. The hard contact lenses can also be used for the correction of the reflective errors as well, right? Either it's hypermetropia, myopia, astigmatism. So in high cases, in high refractive errors, you can use hard contact lenses, and uh, again, because they are more long lasting, they if you are taking the proper care of these contact lens, you can use it up to 1 year if you have adopted the adaptation period, right? So if you have completed the adaptation period and you are adapted to the hard contact lenses, you will feel uh, very comfortable in these contact lenses if as compared to the soft contacts ones. Okay, so they are the type of contact lenses. Only remember that hard contact lenses are the one that stay on the surface of the cornea only. They rest on the surface of the cornea and do not extend up to sclera, and they have smaller diameter as compared to the soft contact lens, and they allow more oxygen to reach to the corneal surface, right? So what happened, but due to this, that the risk of infection and complication is reduced, right? So here you can see one more important key point is that hard contact lenses are always available in the blue color, right? So it is is that so? It is because that it should be differentiated from the soft contact lenses. That is why they are in the blue color. Soft contact lenses are transparent, while or they can be colored as well in different colors as well, but the hard is always in this blue shade, right? So here you can see the soft contact lens has a large diameter while hard has the shorter diameter. They have small diameter, they are smaller in size, and they are blue in color, right? Okay, so now we have the tear lens, hard contact lens. As I have already discussed, that they only sit on the surface of the cornea, right? They do not get adhered to the corneal surface. So there is a space between cornea and the contact lens. That space is filled with the layer of tear, right? So that space is filled with the tear film layer, and that tear film layer act as a tear lens, and it smooths out if there is any irregularity of the cornea. It smooths out all those irregularities. It provides the extra power to the eye, and by giving the meniscus layer, like either minus power, either plus power, we will discuss it later. But here what you should know is that contact lenses hard contact lenses does not adhere to the surface of the cornea, rather there is a space between them where the layer of tears is made, and that tear layer smoothens all the irregularities of the cornea if there is present any, like in case of keratoconus and keratoglobus. Here, what was I telling about tear meniscus? Here you can see the cornea and contact lens is aligned properly in such a way that the tears in between them is evenly distributed, right? So tears over here in the picture one is distributed evenly and does not have any power. So here the tear lens power is zero, where the contact lens and cornea are properly aligned. In the second picture, you can see that the cornea is in touch with the contact lens in the center or in its apex, and while the contact lens is not in touch at peripheries. What is happening over here is that there is a minus lens power induced. So tear lens has a minus power over here. So this tear layer has the minus power, and how or why it is having the minus power? How does a minus lens look like? It looks like it is thin in the center. The minus lens concave lenses are thinner in the center while thickest in the periphery or edges. So here you can see that tear is thick at the edge and is thin in the center. So that is why it is giving a minus lens effect. Whereas in the third picture where the contact lens is steep or is not in touch on the center or apex but is in touch with the cornea at the peripheries, here you can see that it is giving a plus lens effect. So tear lens is giving the plus lens effect, where and how the plus lens or the convex lens is, how does a convex lens look like? A convex lens looks thick in the center and thin in the periphery, right? So similarly here you can see it is thin in the periphery while thicker in the center. So that is how it is giving the plus power. So there are some certain cases where we do not want this aligned corneal and contact lens, right? Alignment there, we don't want this alignment of the fit. So in those cases, either we need a flat fit that it should touch the cornea, or we need a steep fit where it should not touch the cornea, and in that cases we need to adjust the power of the tear lens, right? So we have, I will discuss it later, but right now you should know that what is minus and what is plus effect of the tear lens. So we have the three type of contact lenses of hard type. They are standard RGP lenses, orthokeratology or ortho K lenses, and other one is the bifocal and multifocal contact lenses. The standard RGP lenses, they are made for the refractive error correction like myopia, hypermetropia, astigmatism, and even the presbyopia, right? So if there is any kind of VN correction, for the general VN correction, we use the standard RGP lenses, and they are very highly durable. Next we have the ortho K lenses, and the speciality of ortho K lenses is that it corrects the myopia just by wearing a contact lens at the time of sleep, and it temporarily reshape the surface of the cornea. So the ortho K lenses are the type of hard contact lenses where the geometry of contact lens is reversed. So usually what we know that contact lenses are the shape of cornea, but in the ortho K lenses it is not the shape. The contact lens, the ortho K lenses are not the shape of cornea, rather they are the flat surfaces that is worn onto the patient's eye at this time of sleep. Whenever we patient has to sleep at the time of night, we advise them to wear these contact lens. These contact lens will flatten the surface of the cornea, so the myopia of the person due to curvature would be reduced, and after that what will happen, the person will remove the contact lens in the morning and will able to see the whole day without any kind of refractive correction, right? So they are basically used to treat myopia, and it's not a permanent method, it is a temporary method of reducing the refractive error, and typically that is myopia. So here you can see these are the ortho-K lenses. That this is the curvature of the cornea which was steep. When we have applied the ortho-K lenses, it has flattened the surface of the cornea, and now patient can see uh, without any correction the whole day, next whole day. Next type of hard contact lenses, bifocal and multifocal contact lenses. So these are the RGP lenses, and they are very beneficial for presbyopia and also for those patients who have intermediate glasses. So for that cases, we can prescribe bifocal and multifocal lenses. So now we have the pre-fitting assessment. In the pre-fitting assessment, before advising the or before fitting the contact lens onto patient eye, what should you do before it? So before the fitting of the patient, or before the fitting assessment, or before applying the contact lens onto the patient eye, what things you have to do? You should do the refraction first of all. You should do slit lamp examination. The refraction is done in order to know the proper power of the patient's eye, refractive status of patient's eye, right? And then you have to do the slit lamp examination and thoroughly check the anterior eye, and that eyelids are at place or not. Is there any trichiasis, or all the anterior eye segment should be observed keenly. Then you should do tear film evaluation, that either patient has dry eye or not. If he is having a dry eye, then the patient is not a good um, candidate for using the contact lens, right? Tear film evaluation is done by the Schirmer test and tear breakup test, right? Then we have the horizontal visible iris diameter, that is the distance from one limbus, from medial limbus to the temporal limbus of the same eye. And by this we can further calculate the parameters of hard contact lenses. Pupil size should be measured, and keratometry reading should be done. So now we have three basic hard contact lens parameters that you need to evaluate for every person, that include base curve, total diameter, and the contact lens power. So the total diameter can be obtained by horizontal visible iris diameter, that was the distance from the temporal limbus to the medial limbus of the same eye, and it should be 2 to 2.5 millimeters smaller than the horizontal visible iris diameter. So the total diameter of the hard contact lenses should be less than corneal size. As I have already discussed that they are smaller in, these hard contact lenses are smaller in size. So that is why whatever the size of the limbus, whatever it's a size of limbus to limbus, you have to reduce the size to up to 2 millimeters, and you will obtain the total diameter of the hard contact lens, which typically ranges from 8 millimeter to 10.5 millimeter. And how you can evaluate the total diameter, it is that by subtracting 2 millimeters from the HVID, you can obtain the total diameter of the contact lens. Then we have the base curve, which is also known as back optic zone radius, and it is based on the K readings, right? So those readings that we are obtaining from the keratometry, they are used in order to know the base curve of the hard contact lenses, which is measured in millimeters, and base curve is equal to the flat K. So it is an on K fitting. On K, I mean that flat K. Whatever is the flat K reading, we will just consider it as a base curve for this contact lens. Then we have the hard contact lens power. It can be obtained by the refraction. So using the, if you have done the refraction, and after doing the refraction, what you have to do is that by using the back vertex distance compensation formula, you have to convert the refraction, the spectacle correction power, into the contact lens power. And This is the formula by which you can convert the spectacle power into the contact lens power. So the power you have obtained by the refraction is basically spectacle power, and then you will convert this spectacle power into the contact lens power later. Now we have the tear lens power. The tear lens was the layer which was formed between the cornea and contact lens, which also act as a refractive media and has some dioptric power. So I have already discussed that in a case when it is not aligned properly, either there is a flat fit or the steep fit. In that cases, what happens that tear lens have some power. So how you can calculate the tear lens power? It is base curve minus flat k. If the base curve is a little bit steep, you will subtract it from the flat k. You will know that there is some type of tear lens power. So this is how you can calculate the tear lens power by using this formula. So if you want to convert the base curve into the diopters, you can use further this formula, which is stating as base curve in diopters equal to 337.5 divided by radius of base curve in millimeters, right? So you can simply put the values over here and know that how you can convert the base curve. Now why I'm saying that, what is the need of converting the base curve in diopters? Over here in the length TLN's formula, you need to subtract dioptric readings, right? Base curve in diopters minus flat curve in diopters. That is why you need to convert the base curve in diopter. So I have told you that which formula you can use. Now, hard contact lens power modification is over here. So again, the tear lens power is the one which we do not need usually. If we are giving the power to the patient, if a patient is having plus 3 power and tear lens is giving plus 1 power, so patient needs plus 3, but additionally if I see overall power, patient has plus 3 power plus tear lens is also giving plus 1, so it is plus 4 power. Basically, patient needs plus 3, but due to the tear lens, a power is obtained, an extra power is obtained, that is plus 4, because one diopter was given or added by the tear lens. So patient will have a more power, or similarly patient can have less power than the original, right? If the tear lens is made in minus. So in that case, we need to compensate these tear lens power as well, and this is all done on the basis of the fitting. If you are, what type of fitting you are doing, if there is an ideal fit which I have shown you already over here. Here, this is a aligned. Here the power of tear lens is 0, but here the power of tear lens is in minus, and here it is plus. So that is why it will depend on the fit. If you have given this fit, there will be minus power. Then you have to compensate that minus power of the tear lens by the help of this formula. Contact lens power equals to the power you have compensated, b- b- uh, the power you have taken out by compensation of backward existence. You have to subtract the tear lens power from it, and you will have the final contact lens power later, right? So there are fitting assessment now. There are four things to consider in assessing the optimal fit. That is comfort of the patient, centration, that the contact lens is centered or not, movement, that it is giving an unobstructed movement or not, and later the fluorescein fitting pattern. The fluorescein pattern is evaluated in the hard contact lenses only and is not done in the soft, because soft contact lenses are water loving, and for the fluorescein pattern we need to inject the fluorescein into patient's eye. Not inject, we need to add the fluorescein strip into patient's eye, and later we have to assess the pattern of the contact lens. So if we are applying, we are doing this test for the soft contact lens, what will happen that the fluorescein will be absorbed by the soft contact lens, because they are water loving, and and the color of the contact lens will be disturbed. That is why in soft contact lenses we do not perform the fluorescein fitting pattern. So you have to ask the comfort of the patient after applying or after fitting the contact lens into patient's eye. Ask him that if he is comfortable or not. If he is comfortable, he will tell you that yeah, I am feeling better and I am feeling good. So ask him to tell, and it is totally subjective thing and it is patient dependent, right? Now centration, there should be good centration. If there is no problem recorded, it means that the center of the contact lens and center of pupil is fully aligned. It means the contact lens is properly centered. But if the lens is crossing the limbus during the blink temporally or nasally, you have to note it. If the diameter should not be too much small, that optic zone is not covering the pupil, right? So these are the complications that should be noted while doing the slit lamp examination. Movement is that there should be an ideal amount of movement, that is between 1 to 1.5 millimeters. More than 1.5 will tell you that the flat fit is there. Fit is not, the contact lens is not fitted properly, it is loose, that is why it is moving very much. And if there is less than 1 millimeter, it will show that the contact lens is attached very tightly, that there is no movement. So these things after blink movement should be observed very keenly.